Global health means to me giving your 150% to the patient that's standing right in front of you, no matter what race, identity, culture, sexuality, whatever they are.
Global health is the understanding of health across borders, health in different populations all across the world.
Global health to me is a kind of concerted effort towards equality. It is really a human right that we should be working towards.
Speaking to a refugee in an inner city clinic in New York is part of global health. Speaking to a recent immigrant in a clinic in Los Angeles can also be considered part of global health. Working to better the health care of the individual citizen, no matter what country you work in.
When I think of global health, I think of access to healthcare for everyone.
Throwing yourself in, out of your comfort zone, and learning how to think outside of the box is a big part of global health. I'm learning about the culture experience of the country or wherever you are.
Global health means understanding global communities, but actually acting locally.
Providing equal access to healthcare throughout the world, especially to vulnerable populations that don't necessarily have as easy access as others.
Applying the principle of justice to the way that you view medicine and healthcare in general.
The idea or the concept from my education, cultural competency, that has stuck with me the most is that of cultural humility. So the idea that maybe one will, or maybe it's unrealistic for one to ever be 100% competent in the dozens or hundreds of cultures around the world, but that one can always be humble in in one's own culture that they're bringing to the table, and the assumptions, the biomedical assumptions, the cultural assumptions that they're bringing to the table in a patient-provider interaction. I think the theory of this is obviously really important to be taught in a classroom, and that all healthcare practitioners need to be taught this, but equally as important is the practice of this and being put into a variety of situations and being exposed to a variety of cultures where one can develop cultural humility. I think that's really key to being culturally competent.
My name is Kelly Coleman with the Medical School for International Health. And as you've seen in the last two video clips from MSIH faculty, students, and alumni, global health is particularly important in the world today. Globalization and the increasing interconnectedness of the world has brought both opportunities and challenge for healthcare providers. For academia, it is now more important than ever before to integrate global health into the medical school curriculum. As a result of globalization, healthcare providers serve diverse patient populations, both locally and internationally, who differ in terms of gender, sexual orientation, ethnicity, socioeconomic status, religion, migrant status, and so forth. It's projected by the year 2043, minority groups will become the majority in the US, but this diversity is not reflected in the physician workforce. This makes it more important than ever for cultural competency initiative and trainings at all levels within the healthcare system, but the opportunity is really great to incorporate these initiatives into the medical school curriculum. The goal of cultural competency training in medical school is to educate future physicians so they're able to provide the highest level of quality care to every patient, regardless of race, ethnicity, cultural background, language, or literacy. By increasing their cultural awareness, training, and skills, they will be able to provide the best care possible for patients from any background. This cultural competency training should include awareness, knowledge, and skill development. Awareness encompasses self-examination and in-depth exploration of one's own beliefs and values, as well as one's cultural attitudes and biases. Knowledge really involves seeking and obtaining information based on different cultural and ethnic groups. Based on the awareness and knowledge that the students gain, they should develop skills that will help them better interact with patients and their families. William Osler, the father of modern medicine, memorably said that a good doctor treats the disease, a great doctor treats the patient. And this really speaks to the need for a doctor to understand the patient's story fully. Whether treating a patient locally or internationally, fully understanding the patient and their environment is key to being a great doctor. The Medical School for International Health is a 4-year North American style medical school at Ben Gurion University in Israel and is affiliated with Columbia University's College of Physicians and Surgeons in New York. We have a unique curriculum that integrates global health into all 4 years of the curriculum based on the principles of effective cross-cultural medical practice. Going back to Dr. Osler's quote, we aim to teach our students that we don't fix a broken leg simply because it's broken. We fix it because of the impact it has on the bone's owner. And just as a bone cannot be seen outside the context of the patient should not be seen outside the context of his or her environment. Cultural competency training not only teaches healthcare providers to treat patients from all different backgrounds, but it also teaches healthcare providers to consider a patient's environment, understanding social and economic determinants of health, understanding issues that affect access to healthcare and compliancy, and understanding more than just the science behind medicine are also key components of cultural competency training. We want our students to achieve these goals. We want them to be working with diverse patient populations, meeting the social, cultural, and linguistic needs of their patients, no matter where they come from. We want them to consider a patient's background and environment in terms of treating that patient, understanding the economic and social determinants of health, understanding all the issues that affect access and compliancy for their patients. And this kind of background and cross-cultural competency really places an emphasis on issues of social justice. In the end, integrating cultural competency initiatives and training into the medical school curriculum can enhance the patient-physician interaction, leading to patients feeling more respected and better understood. This, in turn, can help improve health outcomes and quality of care at both the individual and population levels. Such care can also help eliminate racial and ethnic health disparities, serving to create equity within the healthcare system. Cultural competency training is a process rather than an end goal, and it involves building upon prior knowledge and experience. As such, it can be integrated into all years of the medical school curriculum. Cultural competency training should include not only knowledge of things such as social determinants of health, but it should also address attitudes and perceived notions, and it should help to develop skills that practitioners can utilize in treating diverse patient populations. Even in the first 2 years of medical school, cultural competency training can be integrated through courses such as LGBTQ health, refugee health, health of the urban poor, rural healthcare, migrant health, and so forth. Faculty can also help students examine their own cultural biases, their own stereotypes, and their own values and norms. Such introspection can really lead to better self-understanding and awareness. Although clinical exposure is often more limited in the first 2 years, students can learn through early clinical exposure how to interact with patients who speak a different language and how to work effectively with interpreters when they're available. They can also learn about cultural sensitivity in medicine. What is appropriate to ask one patient may be offensive to another. They can learn to better develop listening skills and the skills of nonverbal communication as well, which are really essential to quality patient care. When patients feel heard and understood, they're more likely to heed the advice of their physician, participate in preventative health care, and less likely to miss doctor's appointments. As part of our curriculum, we've also integrated a full year Introduction to Global Health and Medicine course. This is a year-long course at our school that is taught by a Harvard and Hebrew University trained medical anthropologist, as well as an internist and epidemiologist who worked for 10 years with the U.S. Centers for Disease Control. So these two faculty members co-teach this course in a flipped classroom style, really working with case studies to get the students fully involved in the course. The course focuses on understanding context and critical perspectives really needed for physicians who work in any low resource setting throughout the world. They explore social determinants of health and disease burden. They include discussing both the historical context of global health as well as focusing on topics that may be more at the forefront of medicine at any given time. Topics include such things as I've listed here, as Ebola, Zika, right now obviously COVID, tuberculosis, malaria, maternal and child's health, and just the increasing burden of non-communicable diseases in global health. At the end, the students do participate in a big pitch, which is an interesting team-based project where the teams develop a project proposal that addresses a global health need in one of the 7 low-income countries that MSIH has clerkships in. I'm going to talk about that a little later, but the students are given a theoretical budget of $20 million. They come up with their proposal, and it has to be a very comprehensive proposal, and then they present it to some faculty members, the 2 course instructors, their colleagues in the student body, and it's a fun competition, but it's really a good opportunity for students to take a very comprehensive view of a global health issue in a developing country. During the clinical years, workshops and cross-cultural communication skills can continue to develop knowledge and skills for the students. At this point, students are really beginning to feel comfortable evaluating patients, and they may have experienced some of the challenges and frustrations of working with patients from different cultural backgrounds. Workshops provide an environment in which students can learn from one another and experience professionals. Excuse me. In the 3rd year, our students partake in a 2-day cross-cultural communication skills workshop. Students are involved in the entire process of the course, from the initial part of researching and writing case studies, which is done a few weeks prior, to the actual role-playing of different scenarios in the course, and providing feedback on their interactions as well as the interactions of their peers. In these workshops, they explore health-related cultural factors, values and attitudes to health and health-related issues. They discuss the incidence and prevalence of diseases in various populations, as well as research regarding treatments and outcomes for specific diseases within certain populations. They learn more about cultural awareness and communication skills through active participation. They learn to utilize the cultural and health belief assessment tool. Students are able to interact with patients who are actors in this cross-cultural communications workshop. The actors present with various illnesses, but from a standpoint of coming from different varied backgrounds. So the actors present with sometimes the actors present with the same illness, but the approach and treatment may vary depending upon different cultural factors that the students need to learn how to consider. And these are just some of the examples here. But for instance, a patient who presents with chronic lung disease, whether that patient who's presenting is an older Bedouin man living in a tent in a village, the approach may be different than if it's a Bulgarian immigrant without health insurance, or if the patient is a high-tech engineer who may be interested in alternative treatment therapies. So really the same disease, a different approach may be required depending upon the patient, their background, their culture, their socio-economic status. All different factors come into play when we're treating patients, and that's really what this workshop examines. Dr. Galan, who teaches this course, has worked with her colleagues and an MSIH alumni, Dr. Rachel Pope, who's currently practicing in Malawi, to evaluate the effectiveness of these cross-cultural workshops. And their findings really suggest that cultural competency is in fact measurable, and that after participating in these workshops, there was an overall improvement in student performance. And that can be really measured in terms of their increased awareness of their own shortcomings and sensitivity to other cultures. The students who participated in the workshops asked more relevant questions when interacting with patients, and they were able to identify more cultural challenges in the different cases that they were presented with. In addition to cross-cultural workshops like this, in the clinical years, the ability to interact with a diverse patient population also helps students gain hands-on experience. In a clinical setting, students can learn to identify and take into account various social and economic determinants of health as they deliver appropriate quality patient care. The opportunity to work in underserved areas worldwide can also provide really a unique learning opportunity. By working in areas that are very culturally different and lack many of the resources that exist in modern medical centers, students can hone communication skills and other clinical skills that sometimes are overshadowed by the availability of state-of-the-art technology. So for our fourth year students, third and fourth year, they're gaining clinical exposure in Israel as well as North America in various different settings. They're working in Israel itself with a very diverse patient population, Bedouins, the Ethiopian community, Russian immigrants, and a whole host of immigrants in the area of southern Israel. They're also getting clinical experience in North America, working in diverse cities, working in rural America. But for our students, they also get a very unique experience. At the end of their fourth year, the second half, I should say, of their fourth year, they go on a global health clerkship where they really get to experience how physicians and medical practitioners in different cultures promote health and are able to provide quality care despite limited resources. And it's really in these settings that they're able to hone in on those communication skills and improve their clinical skills that, again, are sometimes overshadowed by the availability of state-of-the-art technology. These past few years, our students have done these clerkships in Nepal, India, Sri Lanka, Ethiopia, Ghana, Mexico, Peru, and in Canada. In Canada, it's particularly in Northern Ontario. Following the global health clerkships, as I said, which take part in the second half of the fourth year, students share their experiences with faculty and other first, second, and third year students with the Global Health Roundup. There they come, they present their posters, they answer questions that fellow students or faculty may have, and they learn from one another and their 2-month experiences that they've had. So as I've talked about before, with diversity in the US increasing dramatically over the past decade, cultural competency training is no longer only necessary for those who want to practice medicine internationally. It is really essential for those who want to practice in the United States as well. The increasing diversity of the nation makes it important for all healthcare providers to be culturally competent and learn about cultural sensitivity. And medical schools and pre-med students alike should not underestimate the importance of such training. I would now like to conclude by sharing with you a short video with some insights from one of our alumni, Dr. Martin Gibbs.
I went to med school at MSIH because I wanted to do global health work in my career. I've been fortunate to be able to be involved in good global health projects, both in medical school and since that time, particularly through several years of work in Haiti, where we did things such as a cervical cancer screen and treat project, which screened over 6,000 women who otherwise wouldn't have had access to such care. I've also, unfortunately, seen global health work done poorly. On a recent trip in September 2019 to the Bahamas for relief after Hurricane Dorian, I worked with a small NGO that I'd never worked with before, and I was dismayed to watch the leader of this group break every rule of global health. I saw him walk right past the local providers and local leaders to speak with foreigners who had also come to help about what they were going to do to help the locals. Frankly, I was flabbergasted that this leader of a small medical relief organization could be so oblivious to the most basic tenets of global health work. And I realized that these tenets and strategies seemed so basic to me because I'd learned them early in my career at MSIH. I was very thankful that I had the opportunity to take global health courses and do global health rotations that really got me off to a good start. Moreover, these strategies and principles that we use to help us in our global health work can help in our everyday practice in the US. It's often hard to understand why patients, especially ones from different socio-economic and cultural backgrounds, may do or not do what we think is medically indicated. Using the same strategies we use to partner with our patients and others in global health work, we can do a better job in our work in the US as well.